Today we shall be discussing about fibroids of the uterus. Fibroids are benign monoclonal tumors arising from smooth muscle tissue. In India, the incidence lies between 20 to 30% in women of reproductive age group. This is a picture showing multiple fibroids removed at a laparotomy, and if the fibroid is very big, it can present as an abdominal lump. So this was a case of a large uterine fibroid that we removed at our center, and this is the fibroid mass, and this is the blood vessel supplying the very large fibroid. It was around 30 centimeter in this longitudinal length. The symptoms of fibroid depend upon the location, which we shall be discussing subsequently. So what are the factors that influence the development of fibroids? Genetics play a very important role, and prolonged estrogen and progesterone exposure is the main causative agent leading to development of fibroids. African American and black race are seen to have a higher incidence. Incidence also increases with age, but post menopause there is no increase in size of the fibroid usually. Early menarche is also a risk factor, as is late menopause. Germline mutations associated with fumarate hydratase deficiency, translocations involving chromosome 7-14 and deletion chromosome 7 have also been associated with development of fibroids. Alcohol, high amount of caffeine, diet rich in red meat can all lead to fibroids. Vitamin D deficiency and a high BMI are also risk factors. There are some conditions which decrease the risk of developing fibroids, and one of them being interestingly being smoking. The other conditions are postmenopause, high parity, and use of combined oral contraception. Medical history of hypertension places patients at a high risk for developing fibroids. So the classification that you're seeing on screen here is the classification given by the International Federation of Obs and Gynec. We can also classify the fibroids into two broad categories: uterine and extrauterine. Extrauterine, the fibroids can be present in the broad ligament, in the round ligament, in the ovarian ligament. Sometimes a subserosal fibroid, which is pedunculated, the peduncle might get cut off, and that fibroid can be wandering inside the abdominal cavity. It's also known as a wandering fibroid or a parasitic fibroid. It then attaches to the omentum and draws blood supply from it. There sometimes might be a pedunculated cervical fibroid also, which is also known as cervical fibroid polyp. The uterine fibroids can be also divided into three categories. One is submucosal, which is covered by a thin layer of uterine endometrium. Intramural is one that lies in the muscle fibers of the uterus, and subserosal lies below the serosa. Usually the fibroids are not distinctly subserosal or intramural or submucosal. They can be both intramural and submucosal, having a component of both. This is a large cervical fibroid that we removed at hysterectomy, and this was a central cervical fibroid, and the uterus was sitting upon it, and this gives the classic lantern on the dome of St. Paul's Cathedral appearance. So this is actually the original lantern on the dome of St. Paul's. This is a dome which represents the cervical fibroid in our case, and this is the lantern. So it looks like something like this. There's something called intravenous leiomatosis, which are polypoidal intravascular projections of the fibroid into the veins of the parametrium and broad ligament. Leiomatosis peritonealis disseminata is a very rare condition where multiple small fibroids disseminate throughout the omental and peritoneal surfaces. They are benign. Now coming to the FIGO classification, or Federation of International Federation of Gynec classification of fibroids. They classify fibroids into 8 types. 0, 1, 2 are submucosal fibroids, 3, 4, 5 are intramural fibroids, and 6, 7 are subserosal fibroids. So the type 0 fibroid is that which is completely inside the cavity and pedunculated. Type 1, less than 50% of the fibroid is in the myometrium. Most of it, as you can see, is inside the cavity. And type 2, where more than 50% of the fibroid is actually inside the myometrium. Type 3 is one where almost whole of the fibroid is inside the myometrium, and only a part of it touches the endometrium, contacts the endometrium. Type 4 is one which is completely intramural, not touching the serosa, neither touching the endometrium. Type 5 is a subserosal fibroid with more than 50% of its part being inside the myometrium, and type 6 is a fibroid where less than 50% part is inside the myometrium. Most of it invades into the serosal, subserosal space. And type 7 is a subserosal fibroid which has a peduncle or a stalk. And in type 8 we have two kinds of fibroids that are located in the cervix, or fibroids of the kind 7 where the peduncle gets cut off, and this fibroid roams around inside the peritoneal cavity, attaches to the omentum to get its blood supply. In that case, it is known as a parasitic or a wandering fibroid. This FIGO classification of fibroid is the best to the fibroids and to determine the surgical approach. As we can see, this 0 and type 1 fibroids are inside the cavity, so they can be easily accessed via hysteroscope. So we can go for hysteroscopic myomectomy for these symptomatic fibroids. For type 2 fibroids, it depends upon the size of the fibroid, and if the size is not very big, we can go for hysteroscopic resection. Or if the size is very big, we can either go for reduction of the size by medical management and then proceed with hysteroscopy, or we can directly go with laparoscopy or laparotomy depending upon the surgical expertise of the operating surgeon. For type 3 to 7, which are away from the cavity, it is best to avoid hysteroscopy. Usually, in per speculum examination, we are not supposed to find any fibroids. In case of fibroids, the per speculum findings might be whitish discharge or bleeding, but in 3 cases you can find fibroid in per speculum examination. One is a cervical fibroid which is sessile without a stalk, and the same cervical fibroid either from the anterior lip or the posterior lip has a peduncle. It's known as a fibroid polyp. Sometimes these submucosal fibroids can have a big peduncle or stalk, and they might come out of the external os, and that is a pedunculated submucous fibroid, and sometimes it might be so big that it may prolapse out of the introitus. In that case, it is known as a prolapsed pedunculated submucous fibroid, which is a very rare condition. So summarizing again, fibroids can be classified in the body of uterus as intramural, submucosal and subserosal. In the cervix, they may be anterior, posterior, central or lateral. A central fibroid leads to a lantern on dome of St. Paul appearance, and extrauterine fibroid that might be present in the ligaments supporting the uterus or in the cervix, or wandering or parasitic fibroids. The European Society of Gynec Endoscopy also classifies submucosal fibroids into 3 types. Type 0 is a pedunculated fibroid with no myometrial component. Type 1 is when less than 50% myometrial extension is present, and type 2 is one where more than 50% myometrial extension is present. So this is a case or rare case of a prolapsed pedunculated fibroid. The fibroid was very big, and we had to apply outlet forceps to remove the picture looked like this. This was a very large fibroid, and this is the uterus here. On histopathology, the gross findings include a well circumscribed, round, oval, firm, fibrous mass, which might be single or multiple. And on cut surface, we have a pearly white appearance, hold, and whitish. The fibroids usually have a pseudocapsule, which is actually connective tissue fixing the tumor to the myometrium. In microscopy, we find smooth muscle cells in a hold pattern, and there are interlacing fascicles. Leiomyomas are prone to secondary changes like hyaline degeneration, which is the most common change, mucous cystic degeneration, calcification, and red degeneration. So these degenerations can also be sometimes found in the microscopic picture. Now, a fibroid is supplied with blood supply from the uterine artery. So the peripheral area of the fibroid receives better supply, and the interior area of the fibroid receives less supply. So the interior of the fibroid, central area of the fibroid, is prone to coagulative necrosis if the blood supply is not good, and that leads to central degeneration, red degeneration, which is usually seen in the center because of less blood supply. It's usually associated with pregnancy and oral contraceptive use. And on gross picture, it looks dark red and it has a fishy odor. Now, because the blood vessels are close to the periphery of the fibroid, calcifications are all commonly seen in the peripheral region of the fibroid. The clinical presentation depends upon where exactly the fibroid is. So as we know that in front of the uterus there lies the bladder, and behind it lies the rectum and anal canal. So depending upon where the fibroid is, we will find certain symptoms. Menorrhagia and dysmenorrhea are usually found with fibroid types 1, 6 and 4. 1 and 6 because they are near the endometrium. They increase the surface area of the endometrium, surface area of the uterus. Because of increased vascularity and endometrial hyperplasia, there is menorrhagia. Type 4, because of these similar mechanisms, also leads to menorrhagia, and dysmenorrhea is also caused by these three locations of fibroid. Pressure symptoms are caused, as we can see, if a fibroid is present at the point number 2, it will cause pressure on the cervix. In that case, we will have pressure symptoms on the it will cause pressure symptoms on the bladder. So these symptoms will be frequent urination. It can lead to compression of the ureter, leading to hydroureter and hydronephrosis, and that there might be difficulty in emptying the bladder. We can suppose the fibroid is at position 3, it will cause pressure on the rectum. In that case, there will be constipation and dysphagia, pain during defecation, and the fibroid that is present here, very big fibroid in the pelvis, can cause pelvis pressure symptoms. Fibroid number 1 and 6, because they are close to the endometrium, might interfere with the implantation of the blastocyst and increase chances of abortion. So they are related to primary and secondary infertility. And type 5, that is a very big fibroid close to the cornu, may sometimes block the fallopian tube also, and that might also present as infertility. Very big fibroids also increase uterine contractions and lead to increased risk of preterm labor. Usually fibroids will not present with acute pain, but if a fibroid is presenting with acute pain, there might have been a torsion of a pedunculated fibroid or a hemorrhage into the pseudocapsule or red degeneration. The classical symptom of red degeneration is pain. Suppose we have a fibroid that is rapidly increasing in size and presents with pain in an elderly female. There's possibility of sarcomatous change, and we should investigate accordingly. So how do we go about examining a patient of fibroid? Per abdomen, usually we would not find an abdominal lump unless and until the fibroid is very big. In this case, in this there is actually a visible abdominal lump, because as I showed, it was a 30 centimeter big fibroid. So per abdomen, if you are finding an abdominal lump that is because of fibroid, that will feel firm, will be non-tender, round or lobulated. Round if it's a single mass, and lobulated if there are multiple fibroids. It will have side-to-side mobility, unlike endometriosis, and because it is a solid mass, it will be dull to percussion. What will be the per speculum findings? Only these fibroids will be visible on per speculum: cervical fibroid polyp, pedunculated submucosal fibroid, and prolapsed pedunculated submucosal fibroid. Usually, a patient of fibroid, which is the fibroid which is intramural, submucosal, or subserosal, may have whitish discharge or bleeding because of menorrhagia. You usually do not find any fibroid unless it is a cervical fibroid. We do not find it in the per speculum examination. In per vaginum examination, we go for a bimanual examination. In that case, in case of a fibroid, the uterus will feel enlarged. It will feel irregular if it is a subserosal fibroid, but it will be a smooth enlargement if the fibroid is submucosal or intramural, and it will be firm. Sometimes we may find an adnexal mass if it is a pedunculated subserosal fibroid. The most important differential diagnosis is obviously ovarian pathology. And if we are suspecting fibroid, it might be a broad ligament fibroid or a pedunculated subserosal fibroid. So this is how we do a bimanual examination. One hand presses upon the uterus per abdomen, and two fingers or one finger of the other hand goes into the vaginal cavity and presses upon the cervix. We give an idea about how much the uterus is enlarged. And suppose there is a mass over here, and we are pressing the uterus, pressing it per abdomen vertically like this, then the uterus will go down, and we can feel the cervix hitting the finger. So this is what is known as the cervix moving with the movement of the mass, because uterus and cervix are connected and the mass is inside the uterus. So any movement of the mass will cause the movement of the whole axis. It's important to empty the bladder, otherwise there will be difficulty palpating and giving pressure. We can define the uterine enlargement here and the size of the uterus, and this is how the position is given to the patient. So how do we differentiate between a uterine mass and an adnexal mass? The uterus will not be felt separate from the uterine mass. Cervix moves with the movement of the uterine mass, as I already told. There is no groove between the mass and the uterus in case of a fibroid, but if it's an adnexal mass, you will find a prominent groove. Please note that if it is a subserosal pedunculated fibroid, all this wouldn't apply, because it will actually feel like an adnexal mass, and because it's connected to the uterus by a small pedicle, you can actually find a groove also between the mass and the uterus. There is another important differentiating sign which helps us differentiate between the adnexal mass and the uterine mass. In this case, what we do is, it's known as Hingorani's sign. We examine the patient in Trendelenburg position, which results in the upward displacement of the adnexal mass. So the groove between the uterus and the adnexal mass becomes prominent. But if it's a uterine fibroid, any position would not cause the groove to be delineated. Now, broad ligament fibroids can be true or false. True broad ligament fibroid arise from the muscle fibers in the parametrium. The uterine artery and ureter is medial to the mass. False broad ligament fibroids are those which arise from the lateral wall of the uterus or cervix, and they lie between the layers of the broad ligament. the uterine artery and the ureter lies lateral to the false broad ligament fibroids. So, how do we document the size of a enlarged uterus which is having fibroids? It's done the same way as we document the size of a gravid uterus. So, let us revise it once. If the uterus can be palpated at the level of pubic symphysis, then that is around 12 weeks size. If the uterus can be palpated at the umbilicus, then that is around 22 weeks. Exactly in between, midway in between umbilicus and pubic symphysis, if we are feeling the uterine fundus, then that corresponds to 16 weeks. Come back to the umbilicus. One finger below the umbilicus is 20 weeks, and one finger above the umbilicus is 24 weeks. At the Zephyr sternum, if you're feeling the fundus of the uterus, it is 36 weeks size uterus, and midway between the Zephyr sternum and umbilicus is around 28 to 30 weeks. So this is how we document the size of the uterine enlargement. So what are the differential diagnoses? Anything that causes uterine enlargement: pregnancy, blood in the uterus, pus in the uterus, adenomyosis, uterine sarcoma, and endometrial carcinoma. And if you are feeling an adnexal mass, then the differential diagnosis will be definitely an ovarian tumor or a ovarian mass, or ectopic pregnancy, pelvic kidney, or chocolate cyst. So how do we investigate? We send the usual see complete blood count, the blood group, urine routine, ultrasound, pap smear. If you're planning a surgery, then pre-anesthesia workup and endometrial biopsy. So let us come to the first investigation modality, imaging modality, that is ultrasound. What will ultrasound depict? It will depict a well-defined, rounded hypoechoic mass with or without cystic spaces. If there are cystic spaces, that implies that there is degeneration. The fibroid the size can be documented, the location can be documented, and the number of fibroids can be documented. USG also tells us whether there is ureteric compression, which is leading to hydroureter or hydronephrosis. If suspecting leiomyosarcoma, then the modality of choice of investigating modality of choice is MRI. When do we do a Doppler in case of a fibroid? The Doppler actually helps us in differentiating between a fibroid and an adenomyoma. In a fibroid, the blood flow will be surrounding the mass, but in an adenomyoma, there will be diffuse blood flow. So this is how a Doppler helps in the differential diagnosis. 3D USGs can be used for exact localization. These pink colored structures are the uterine fibroids on the posterior wall of the uterus. We also use HSG, hysterosalpingograph. This is the HSG picture, and this filling defect shows a submucosal fibroid. We can do an hysteroscopy, and hysteroscopy is a very good modality to detect submucosal fibroids, as in this case. MRI is also used here. This is the fibroid on the MRI, and specifically MRI is to be done when we are suspecting leiomyosarcoma, or in a virgin or elderly female when pelvic examination is not desirable, or ultrasound findings are suspicious. Fibroids are estrogen dependent pathologies, so they are usually associated with other estrogen dependent pathologies like endometrial hyperplasia. And adenocarcinoma of the endometrium is the most common malignancy observed in women with fibroids and abnormal uterine bleeding. So if we have a patient with fibroid with abnormal uterine bleeding, it is very important that we do an endometrial sampling before we plan for any major surgery. First, it helps us to diagnose if there is any endometrial adenocarcinoma or uterine sarcoma. Secondly, if we have ruled out this malignant potential, then there is no problem during morcellation or breaking down of the fibroid in case of laparoscopic removal. Morcellation is a process by which a very big fibroid is broken down into small pieces and then retrieved from the small laparoscopy ports. But various studies have shown that this cutting up of the fibroid into very small tissues can lead to sometimes spread of this tissue, and it increases the risk of spreading occult uterine sarcoma. But if we have done a DNC and you have ruled out sarcoma, then this risk during morcellation is done away with. We can also do laparoscopy if our patient presents to us primarily with infertility, and we can do IVP if ultrasound suggests the possibility of hydroureter or hydronephrosis. So in the next video, we shall be going through the complications of fibroid and the management of it. Thank you.